Hello, everyone, and welcome to Adherence-Informed Clinical Trials to Achieve and Maintain Maximal Treatment Efficacy, presented by MWV Healthcare. I'm Morgan Edwards-McGee, Operations Manager of Life Sciences at Fierce Markets, and I'll be moderating this webinar. Our speaker today is Dr. Bernard Vrayens, Chief Science Officer at MWV Healthcare. You can read his full bio on the right side of your window. Just a few technical notes before we begin. If you have trouble reading a slide, please hold and drag the right corner of the slide window to enlarge. Please also disable your pop-up blocker to participate in the interactive parts of the presentation. To download a copy of the slides, please click the Download Slide widget at the bottom of your screen. We'll be following the presentations with a Q&A session, so please submit your questions during or after the presentation using the Q&A box at the right side of your window. So I think we're ready to begin. Bernard, please go ahead.
Thank you, Morgan, for the introduction. And yes. So I will start by acknowledging that today we have very effective therapies, but if we do not have appropriate adherence to the medications, we will not reach effective disease management. And in our field of research, which is medication adherence, there is a very famous sentence that says drugs don't work in patients who do not take them. Most of the adherence talk will start with that sentence, but this sentence assumes that adherence is a dichotomic process. Either you are adherent, either you are not adherent, while in reality it's more complex, as adherence is a dynamic process. And in the next slide, I will define what medication adherence is. It's a process by which patients take their medication as prescribed, and we have to recognize that it is a dynamic process over time, and that there are three key elements. Once there is a prescription, the patient has to initiate the therapy. Once the therapy is initiated, the patient has to implement the dosing regimen, meaning taking it once a day, twice a day, with food, without food, and sometimes when we think about polypharmacy, this implementation can be pretty complex. And then the patient has to persist with treatment, sometimes for a long period of time, especially in chronic diseases. So what can go wrong? Either the patient does not initiate, and that's typically a dichotomic outcome, it's yes, no. Either the patient delays, omits, or takes extra doses, and that's a dosing history. Or the patient discontinues treatment, and that's a time to event, statistically speaking. And as you can see, those three elements are very different in nature, and that's why it's important to study them separately. Okay. Now, to study medication adherence, it's important that we can measure medication adherence. And here we have summarized the different methods of measurement for medication adherence. And as you can see on the vertical axis, some of those methods are reliable, while some of those methods have proven to be extremely biased. Like, for example, when we do pill counts, which is a very popular measure in clinical trials, we know that patients tend to drop the pills before showing up at the visit, or retrospective questionnaire asking the patient if he took the medication is extremely biased. On the upper side, therapeutic drug monitoring is extremely reliable because we know when the medication is taken. However, therapeutic drug monitoring, which is blood concentration measurement, is a very sparse measure of medication adherence, as you have an idea of the medication when it's taken at the time of sampling, but nothing before. And most of my research has been focused on electronic monitoring, which is the idea of putting a chip in the package so that every time the patients access the package, it's time-stamped, and we know precisely how the medication is taken. Just to give you a flavor of the data that we are collecting using those smart packages, here is one example of one patient taking a twice-a-day medication, and in this figure, on the x-axis, you have the days of follow-up. On the y-axis, you have the time of drug intake. So now every time there is a blue dot, it's a dose taken. So you see that this patient takes the morning dose about 7 o'clock in the morning, always at the same time, and he takes the evening dose also at 7 o'clock in the evening. He was once 2 or 3 minutes late, but besides that, he's very precise and never missed a single dose. Furthermore, there is exactly 12 hours between the morning and the evening dose. So this is really a patient with ideal adherence, and as you can imagine, a lot of patients do deviate from the perfect profile. One example of deviation that we see very often is variability in the time of drug intake. So in this example, for example, you see that the patient takes the morning dose on weekdays around 7 o'clock in the morning, while the morning dose on weekends is taken much later, about noon, as the patient is sleeping out. In the evening, you see also more variability in the time of drug intake, but here it's still a very good adherent patient because he never missed a single dose. Another example is this one, where you see that the patient in the morning is taking the dose pretty well at the beginning of the study, but then further in the study you see that he is starting to miss a lot of dose. In this figure, every time there is a gray line, it's a missed dose, and you see that at the end of the follow-up, the patient is almost taking nothing anymore, especially in the evening. The last example I will show you is this one, and I like to show this example because you see how dynamic the process of medication adherence is. You can see that this patient at initiation has some trouble taking the medication. He missed quite a lot of doses. Then he is doing much better over the course of the study, still missing a few doses, and then about halfway he is discontinuing treatment, he is stopping the medication, so it's a non-persistent patient. And I could show you thousands of those patterns as we collect them in many manic patients, but here is a summary to summarize the extent of non-adherence in clinical trials, and this is a summary of about 17,000 patients that we have monitored using those electronic monitors in about 95 clinical trials. So if all patients in those trials will be perfect adherent, meaning they would initiate treatment, implement perfectly, and persist with treatment, we would have the horizontal line. Everybody would be at 100% adherence on the top line. However, the first summary that I provide you here, it's the blue line, it's the persistence curve. So this gives you the proportion of patients who persist with treatment over 1 year in those 95 clinical studies, including almost 17,000 patients. So you can see that after a year, we have lost about 40% of the patients. And it is striking that to see that on day one, on the left-hand side of the figure, on day one, you see that the blue curve drops of about 3 to 4%. That means that even in clinical trials, where the patients are highly selected, highly motivated, and receive the study medication on site, 3 to 4% of them walk back home and never open the package. Then the next figure, which is the red line, gives you the proportion of patients who open the package as prescribed on every consecutive days. So that's the adherence curve. So it means that if you take, for example, day 100 on the x-axis, you can see that about 80% of the patients are persistent with the treatment on day 100. That's the blue curve. While on the same day, only 65% of the patients do take their medication as prescribed. So we have a gap here between the blue curve and the red curve of about 15%. So in summary, what we can see from this figure is that after a year, we have a decrease in adherence due to discontinuation, due to non-persistence of about 40% of the patients after a year. And every consecutive days, among the patients who are persistent with the treatment, we see that we have a decrease in adherence due to poor implementation of the dosing regimen of about 15%. Now, if we look persistence across the different diseases that we have studied in that study, you can see that there are major differences between diseases, and we see the worst persistence in depression. So it's really in patients with depression that we see the worst persistence, and we have also to think about all the diseases that are associated to depression, like, for example, multiple sclerosis or oncology, where the level of depression is high. We have to be very careful about persistence with those treatments. So, in summary, I would say based on the data that we have collected in those many clinical trials, we have a major adherence gap. And typically, when we think about drug development, phase 1, phase 2, phase 3, today, most people think that we are measuring the full efficacy of treatment or the effectiveness according to the method, and that in the marketplace we have a gap because we are measuring more the effectiveness of treatment, and there is a gap due to non-adherence. But in my view, this view is past, because we have also non-adherence in clinical trials, as I just showed you in the previous slides. And so my view is that after the phase 1 study, once we move towards phase 2, phase 3, and we include real patients in our clinical trials, we have suboptimal adherence. But we are still doing better than in marketplace, in the practice, because we have still high patient selection and better patients follow-up. That means that when we conclude our clinical trials, we end up with an estimate which doesn't answer the FDA question, which is what's the efficacy of treatment, and which doesn't answer the payers' question, who want to know exactly what the effectiveness on treatment. So we are ending up with an estimate that is in between and which can be very misleading in drug development. And this gap leads to a major risk of failure related to lack of effectiveness. It leads to poor estimation of toxicity. It often leads to inappropriate dosing regimen and major loss of revenues. And we have to realize that adherence is becoming a regulatory priority, as it is already mentioned in the draft guidance that were issued in 2012. A few examples. I think this example published in the BMJ shows the major issue and shows also that even with a treatment for hypertension, a treatment that is once a day, easy to take, we still have issues about medication adherence. We see that about half of the patients will stop treatment after a year. And if you look here on the lower left figure, you see that there are a lot of missed doses. Here you have the proportion of missed doses on the y-axis against the day of the week, and you can see that the patients who take the dose in the morning are pretty good adherers. Those are the ones who miss the less doses in green. But then the patients who take the dose in the evening, they miss more doses, and especially on Saturday evening. And then the ones who take the drugs at variable times, those are the ones who didn't build a very clear habit of taking the medication. They take it any time of the day. This is a proportion of patients who really missed many doses, and also with an increase on Saturday evening. It's also important to note on the right-hand side and on the lower figure, those are the persistence curves stratified by implementation, and you can see that the better a patient implements a dosing regimen on a day-by-day basis, the longest he persists with treatment. And that will guide us when we are talking later about intervention, that it is important to help the patients to build a habit and to implement on a day-by-day basis so that he will persist longer with treatment. So hypertension is a very clear example where non-adherence is affecting the clinical outcome. But just to give you a couple of other examples, this is one example about the prevention of HIV. And in HIV prevention, there has been several studies showing that adherence had a major impact on the success rate of HIV prevention. And this figure, the upper figure, summarizes the different studies. So the area in green gives you the level of adherence in those studies, and the point estimate and the confidence interval give you the level of efficacy. And you can see that there is a very strong relationship between the adherence and the level of efficacy. The first study, the adherence level was less than 30%, and the efficacy was 6%. And then, as the study was going on and going down, I would say, in the figure, you can see that there were more and more intervention and more focus on adherence, and you can see the efficacy going up. So when we look at the intention to treat analysis of those data, the success rate was about 47%. But when we look at an adherence-adjusted analysis, or when we look at the last study, which had a major focus on improving adherence using feedback from electronic monitoring, you can see that the level of adherence was almost 95%, and the level of efficacy was 100%. So, based on an adherence-adjusted analysis, this drug was put on the market, but there were major comments coming out of that study, and what came out very clearly is that adherence based on self-report and pill counts was not reliable, and that it was necessary to have more reliability of adherence data in clinical trials. And at the end, the last point which was striking in my view is that no covariate can have a larger impact than not taking the medication. And so it's very important that in the future we better understand adherence in our drug development phases. A last example that I wanted to show you is a study that was published last month, and it's a study in which about 500 children with acute lymphoblastic leukemia were monitored using electronic monitoring. And you can see in this figure that the children with an adherence level above 95%, so the very good adherer, I would say, had a relapse rate which was close to 5%. While in the children where the adherence was below 95%, the relapse rate was about threefold higher, 2.7-fold higher than in the non-adherent children. And what was striking is that about 40% of the patients of those children in this life-threatening disease were classified as non-adherent patients. So that means that even if in life-threatening diseases there is suboptimal adherence, and it leads to major clinical implication. And so it's very important also that when we think about precision medicine, it's not only about finding new medication, but it's also about better use of existing medication. And there was a call in Nature published end of April this year, thinking that asking for precision in medicine and suggesting that it was time for one-person trial. And just to highlight the importance of precision medicine, in the figure on the right-hand side, they show what's imprecision medicine. And it highlights that in blue, the number of patients who would benefit from treatment when it's taken, compared in red to the patients who take the medication and don't benefit from it, based on number needed to treat. And you can see that across many therapeutic areas, it's striking how imprecise we are today in treating patients and in managing patients with very effective medications. And I think it's no more acceptable to ignore one of the major sources of variability in drug response, which is medication adherence. And when we think about the different sources of variability, it is striking to see how much precision is required in manufacturing of a medication and distribution of a medication, how much precision is asked in the prescription and dispensing, which are professional activities. It's also very clear that pharmacokinetics and pharmacodynamics are biological processes, but they are extremely well studied in drug development. There is a strong focus in studying pharmacokinetics and pharmacodynamics in drug development, while adherence is completely ignored. It's completely ignored that patients may skip a dose, omit a dose, take an extra dose, and that, I think, in the future needs to be taken into account in the equation. And in the future, it's very important that we better understand what are the consequences of non-adherence. And again, here, if we think in the three elements of medication adherence, it's clear that drugs will not work in patients who do not take them, who not initiate them. It's clear that drugs will stop working in patients who discontinue them. But the key aspect that is very often neglected is that drugs will work partially or may even create harm in patients who implement a dosing regimen sporadically. And that's something that we need to better study, and it's drug specific. It depends on the drug's forgiveness. Let me spend one slide in introducing this concept of drug forgiveness, because typically when we give a treatment to a patient, and here is an example of a treatment once a day to a patient, we expect that the concentration, the blood concentrations or the pharmacokinetics will rise and after a few days reach a steady state and maintain a steady state over time. And the idea is that the drug exposure is within a therapeutic window, meaning it's above a threshold where if it goes below, you have periodic loss of effectiveness, and it's below the toxicity threshold. If you go above, it increases the risk of toxicity. So the idea is really to dose in the middle of the therapeutic window. Now, if we simulate 3 missed doses here, for example, you can see that the treatment will remain efficacious for about 24 hours. So we can say that the treatment is forgiving for 24 hours. It's forgiving for a missed dose. Also, if a patient takes an extra dose about midday because he realizes he missed a dose, for example, you can see that the treatment will be forgiving also for 1 extra dose. So that's the idea of forgiveness and how broad is that window around the dosing schedule. So very often when we dose a patient once a day in this example, you can see that the patient after a few days reaches a steady state and maintains a steady state over time. And we think when we say this patient is on treatment, that's all the picture that we have in our mind. The patient is dosed and maintained that steady state over time. Well, in reality, it's very different because patients miss a dose, take an extra dose for those they have missed the day before to compensate the dose they have missed the day before. Patients take a little drug holiday, and you can see that there is much more variability in that dosing exposure process. And eventually, depending on the therapeutic window, this can lead to occasional toxicity or periodic loss of effectiveness. And in the future, we need to better understand the impact of this variability on clinical outcome. And just to give you one example, in the field of anticoagulation and the new anticoagulants, the idea is to dose the patient within a window and to be above the risk of thrombosis, to reduce the risk of thrombosis, and below the level of reducing the risk of bleeding. So the idea is really to dose within that therapeutic window, and you can see if for a same treatment, a same drug, you have the choice between giving it once a day or twice a day. You can see that by giving it twice a day, you reduce systematically the variability within that therapeutic window. And we know that there is a trend to go for once daily dosing because it's easier to take and it's more convenient to take for patients. However, one has to realize that by going for once a day, any deviation in the process of adherence, so any extra dose or misdosed, may lead to clinical risk, increased risk of thrombosis or increased risk of bleeding, while for the same window, if you give it twice a day, it's more forgiving, and with the twice-a-day dosing regimen, it's only when you have major mistake, like missing 3-4 consecutive doses, that you start to be at risk of thrombosis. So it's a trade-off between more convenience with once a day, but building more forgiveness in the treatment with twice a day. And that's an aspect. Very often people compete in the market promoting simpler dosing regimen, But in reality, we need to better understand what are the consequences of those dosing regimen, and we need to better understand the consequences of the doses that we pick in drug development. And this can only be done if we have reliable measurement of adherence in drug development. And today, we have to recognize that the methods we use, which are pre-electronic, are very unreliable. I mentioned to you that pill counting was extremely unreliable, but here is an example on the upper left figure. This is a study I always like to show because it's a study in which the investigators have given 160% of drug supply. So rather than giving 100 tablets for 100 days, they have given 160 tablets for 100 days, so 60 too many tablets. And you can see that there is a very nice Gaussian distribution around what they are expected to take, indicated by the blue arrow. But you can see on the right-hand side that about 20% of the patients in that study brought back an empty bottle, meaning they dropped the pills before coming to the visit. And it is well documented in about 100 different peer-reviewed papers that pill counting is drastically overestimated medication adherence. Also, on the lower left figure, you can see this is an extreme case of dosing, and in this study, patients there were blood sampling to see if the patient was taking the medication. And you see one example here, and it's an extreme example, where the patient is taking the dose, coming for the blood sample, then takes nothing, takes 2 doses, takes for the blood samples, takes nothing, takes 3 doses, and comes from the blood samples. And you can see that this patient will be okay regarding blood concentration, pharmacokinetics, but in reality, he is not taking the medication at all. And we have shown in a publication here that there is bias in 31% of the samples, and it's clustered in 66% of the subjects. So meaning that the blood concentration taken at the visit doesn't represent the adherence of the inter-visit period. We know also on the upper right that self-reports is always extremely high, reports very high level of adherence, and clearly much higher than electronic monitoring. And finally, healthcare providers have not been better than a coin toss to predict patients' non-adherence. So when we realize that today in drug development we are still using self-report and pill counting in to evaluate adherence in drug development, it's a very biased measure. But bias is not the only issue. I think that the richness of the data is even more important. And just to give you an example here, I show you 4 patients for whom we have electronically compiled dosing history data, and the 4 patients have taken exactly 75% of their prescribed doses over a 3-month period. So they all have taken exactly the same amount of tablets. And you can see that the first patient missed mainly evening doses, the second patient missed morning and evening doses, the third patient, when he missed doses, those are consecutive doses, and those are drug holidays. And the last patient, as you can see, he implements perfectly but stops too early. And you can imagine that the clinical consequences of those 4 patterns will be very different. And that is why, in the future, I think it's very important that we collect this type of information to better inform drug development. The strong aspect of electronic monitoring, because it detects package entry, so it's really a measure of pill in the hands. But its strength is that when you collect the dosing history, you can predict the drug levels. And we did several studies showing that there was less than 3% discrepancies between projected and observed concentrations when you use electronic monitoring of adherence in drug development. So it gives you really the ability to have a good estimate of drug exposure throughout your clinical trials. And today, when when somebody expects an issue of adherence, typically in drug development, there will be some measure of concentration, some sparse measure of concentrations. And in my view, it is too sparse. We need a much richer method to measure adherence. And those are two examples that I selected to show you. And those are two examples. You can see that in those two examples, on early in the study, there was an intensive pharmacokinetic day in which the different samples were taken for a same patient. And based on those samples, the expected concentration range was plotted here in pink. And then 4 concentrations were taken in those 2 patients, and those 4 concentrations were expected to be at trough, meaning just before the next dose. And when you see the first patient, he has one of the trough concentration, the first one, which is much higher than expected. The second one is as expected, the third one is lower, the EC50, and the fourth one is as expected. So it's very difficult to decide if this patient is adherent or not, and if we want to do a dose adaptation, how do you adapt the dose? Because the first concentration will indicate that you have to reduce the dose, while the third will indicate that you have to increase the dose. But when we look and we combine those concentrations with electronic monitoring of adherence using package entry, you can see that the patient, the first concentration was catched while he was not at trough, and one of the concentration, the third one, was catched when he missed a dose. But you see the picture, from the picture, you see that this patient was pretty well dosed, but there was some variability due to non-adherence. And if you look at the second patient, you can see that the concentrations were as expected almost, but using electronic monitoring, we were able to show that this patient had much more variability in the dosing process than was expected, and that could lead to eventual losing efficacy of treatment, and for HIV, there could be some emergence of drug resistance. So I would say that today, when we do clinical trial drug development and clinical trials in drug development, we have no information on adherence. And it's very difficult to select what's the best dosing regimen, optimizing the balance between efficacy and safety without any information on adherence. And what we realize is that when we have the phase 1 study, we have a very good idea of what's the formulation of the drug, we have a good idea of the pharmacokinetics, pharmacodynamics, but we have very little idea about adherence, or no idea about adherence. And the trend is really to select the highest safe dose to compensate for diluted efficacy due to non-adherence, but there is a high risk of side effects and adverse effects. So in this setting, it is very difficult to find out what's the best dosing regimen, and I think there is clear room for improvement. And when we look the reasons for delay or denial of FDA approval of drug in the last, there is a difference here between the 90s and 2000, we see that we have done a major improvement regarding pharmacokinetics and bioavailability of the drug. There has been a very strong focus on pharmacokinetics. In the middle of the figure you can see, and we met the challenge there. We did a great job. But when we look on the right-hand side, commercial toxicity or even efficacy, we can see that we are not doing better than in 1990, and we are even doing worse regarding toxicity and commercial. And I think that adherence clearly can improve those those reasons for drug and not approval, and it has been underestimated until today. So in my view, adherence-informed clinical trials, there are major opportunities in the market, because there are opportunities to save time, because it will deliver better informed benefit risk and development decisions, and there will be shorter time to set the optimal dosing regimen. There will be major cost savings because we will have greater efficacy and lower variability, leading to increased power or decrease in sample size, and fewer post-approval dose reduction. And at the end, the most important is that we will have improved therapies, more informative safety, and more effective dosing regimen. And so, in my view, it's time today to really improve drug development and to include adherence in drug development. And when we look at electronic monitoring, I think today it's a very proof answer to adherence-informed clinical trials, and it has 4 decades of history. It started late in the 70s, and there has been about 10 years of discovery. And this figure gives you the number of publications over the years using electronic monitoring. And then the 10 next years has been about acceptance and then deployment, and now we are really integrating this large scale in clinical trials. And you can see that as of today, there are 700 peer-reviewed publications reporting data on electronic monitoring of adherence. It has been cited 50,000 times, and it has an H-index of 112, meaning that there are 112 papers using electronic monitoring that have been cited more than 112 times. And so I would say that the structural approach is no longer an option, because in the past we have dealt and we have developed a lot of treatment which had a very wide therapeutic index, a very wide therapeutic window. And it was possible to pick a higher dose to build a lot of forgiveness in the treatment, so that even if there were some variability in the concentrations, we would still have the full efficacy. But when we think today the drugs we are developing, and when we look at the pipeline in the industry, we are more and more in phase of drugs that have a very narrow therapeutic index. And we can think about the new anticoagulants, but we can think about multiple sclerosis, we can think about oncology treatment, infectious disease treatment. The therapeutic indexes are much, much more narrow than in the drugs in the past. And in that setting, we cannot ignore any adherence anymore. We have to find the optimal dose, the optimal dosing regimen, and manage medication adherence in the future. So in the past, when the patient was not taking the medication, we would say it's a problem of the patient. But the cost associated to non-adherence becomes so important that today it's the system that has to take medication adherence into consideration. It's the patient, the family, the providers, the community, and the healthcare policy. And the objective of improving medication adherence is not to improve medication adherence. Adherence is not an end by itself. The objective is to achieve the best use by patients of appropriately prescribed medicines in order to maximize the potential for benefits and minimize the risk for harm. That's really what we want to achieve, and that is why, if we want to improve medication adherence, we have to better understand the consequences of non-adherence throughout the drug development process. And in the management of adherence, it has been very striking from the different clinical trials we have done that if you have a good measure of adherence, you can manage it. And this is one of the first studies we did. It's a case study that I show you here, but this patient was monitored for 3 months on the left-hand side, and you can see he did miss a lot of doses. And then those data were downloaded and discussed with a pharmacist in this case. And you can see a drastic change in his behavior afterwards. And in this study involving about 400 patients, we had a 15% improvement in adherence. But today, we did a review of the literature, and there are about 20 studies that have used this electronic monitoring feedback to patients, and making the patients and the healthcare provider aware of the deviations in adherence allows to have a focused discussion between the healthcare provider and the patient, and that has the strongest impact on improving medication adherence today. So my view is that what are the elements to change patients' behavior? So it's very important to educate the patients to increase knowledge. It's very important to motivate the patients to increase self-efficacy. But by itself, those 2 elements are not enough. We need to implement good measurement to increase awareness of the patients. And if we have good measurement, we can set goals and motivate the patients. So in my view, those are really the 3 elements we have to work to improve and to change the behavior of patients. So measurement is often neglected, but it's a very key element to manage patients' adherence. Now, if we think about what are the measurements available to measure the three elements of adherence, and if we think about direct methods like measuring blood levels, which is often what comes first in mind when we are talking about medication adherence, I think that I showed you that the sampling is way too sparse to measure implementation, and it's subject to white coat adherence, meaning the patients can just take a dose before a visit and it looks like the patient is persistent. So it's not a good measure of adherence at all. Self-report is affected by desirability bias, that's very well known, but also it's affected, especially for the implementation phase, by recall bias. You cannot ask the patients to remember what they forgot 3 months ago or the past week or past months. They are not able to recall this information. That's the recall bias. Then we have pill counting, which is easily censored by the patient and only gives you an aggregate summary of implementation. It doesn't give you the detailed information to take this information really in drug development and in the modeling process. I think that prescription and refill databases are used and should be more used in the future, especially in medical practice outside the clinical trials, for detecting the patients who do not initiate a treatment and detecting the patient who stop persisting with a treatment or stop persisting a class of treatment, because the great advantage of refill databases is that it allows you to detect switches within a same class of medication. And this, I think, should be better used in the future. I know there are some settings where it's used in the US, in Europe, but its use will be growing. And electronic monitoring, in my view, it's really the gold standard for clinical trials, but also in medical practice when you want to have a precise measure of implementation, which is not always required, but for some drugs with a very narrow therapeutic index, it will be required. Electronic monitoring is the gold standard to measure implementation of a dosing regimen. Finally, I would like to take your attention about what could be done very easily and what can be scaled up very easily to provide the patient with a self-measure of implementation. And it's amazing how much efforts we do to package food, beverage, and everything in the world, and how little attention is given to packages in healthcare. And I think that calendared packages can provide the patient with a self-measure of his implementation of a dosing regimen. And it's underused today very clearly, but at initiation, it provides valuable information to guide the patient. You can activate patient's program, but clearly it increases the awareness of missed dose for a patient. So if you are Wednesday and the Tuesday pill is there, it means you forgot to take it. And making the patients aware of that can clearly help his medication adherence. It will motivate habit-building strategy. It allows the patients to check that he executed the habit. How often the patient says, did I take my medication? I don't remember. With a well-designed package, you can avoid this type of doubt. He can check directly if he took it or not, and at the end, it will also prevent overdosing. And this is a very scalable solution that can contribute to longer persistence. It's not the only solution, but I think using calendared packages and well-designed packages can clearly help the patients in the medical practice. So, and using calendared packages does improve adherence, and we did two studies in which we have shown it significantly improved medication persistence. So, in conclusion, if we want to manage medication adherence, there is not one solution that fits all, and we have to think about the three elements. What can we do at initiation? At initiation, I think education to increase knowledge is very important. Training to increase the skill of the patient is very important, and we have to motivate and set goals for the patients. But then what can we do for implementation? And when we think implementing a dosing regimen on a day-by-day basis, what is very important is to build the habit of medication taking. We have to make the patients aware what's the cue that triggers the medication intake. When does the patient take the medication? Is it at breakfast? Is it at dinner? Is it at bedtime? Does he put the medication next to his coffee machine to see it when he wakes up? So we have to identify those cues. We have to simplify the routine, and the patient has to perceive some reward. And the only way to build that medication habit is to make the patients aware, to measure it and to feedback on it. And that's very important. And finally, what can we do to persist longer with the medication? And that we have to track follow-up measurement and encourage habit of formation, motivate the patient, and education. Persisting education is important. So there is not one solution. We have to think separately for the different elements of adherence, initiation, implementation, persistence, and it's a combination that will be most useful. So if we think what can we do in practice and what are the methods that are scalable to address medication adherence, I think that the use of prescription refill and e-prescription and pharmacy refill, it's a scalable approach that will be used in the future principally to detect the ones who don't initiate and detect the ones who don't persist with treatment over years very often. But we have to realize that this measurement of adherence is very sparse. It only gives you an aggregate measure of adherence, and it's a very poor measurement of implementation of a habit, and it's a very poor measurement of the implementation of a dosing regimen, and it doesn't help really to build a habit within a patient. So for treatments that have a narrow therapeutic index, I think that smart packages and electronic monitoring can be used at treatment initiation or at treatment failure or in patients where a problem is suspected. There is a potential to use electronic monitoring for a defined period of time to help building those habits in medical practice. In my view, in clinical trials, the setting, the system is simple. We know when the patients start, when the patients end, who will do it, and it's key to have this type of measurement, electronic monitoring, in clinical trials to improve the selection of the dose and the dosing regimen in the future. For me, it's no more acceptable to have a measure like pill counting or self-report for a key variability element in the drug response. So in my view, in trials, it should be used always electronically. But then in practice, I think that calendarized blister and packages activated adherence program will help the patients to self-measure that adherence and to build their habit in the future. And that's easy to scale in broad population, and the combination of electronic prescription and well-designed packages, in my view, is the future for clinical trials and for medical practice. So today, I would say that poor adherence, whatever, if it's poor non-initiation, poor implementation, or non-persistence, is present in a lot of situations across almost all therapeutic areas. And when there is poor adherence, very often the treatment fails. And if adherence is not recognized, the disease will progress, and what will happen is that the treatment will be more complex. Either we give a second-line treatment, a third-line treatment, or we add a treatment, or we increase the dose, and we make it more and more complex for the patient. And if the treatment is more complex, it will be worse for adherence. and the adherence of the patient will even be worse, and the treatment will fail again, and the disease will progress, and that's the loop. And this is a very, very costly loop if the origin of the problem is medication non-adherence. So we have clearly to break that loop, and it will be very important that we address medication adherence to avoid drastic increase in cost in the future in the healthcare system. So with this slide, I would like to end, and I give it back to Morgan for the Q&A session. Thank you.
Thank you, Bernard. Great presentation, very informative. Now we can move on to the Q&A session. We have lots of great questions, and we'll try to get to as many as possible. Our first question is there pharmacodynamic evidence that acceptable variable adherence in an almost sine wave-like pattern can produce better results than strict linear adherence because of perturbation in the body's systemic compensation for drug effect over time?
Wait, I'm looking at the question because it's a very long question.
Yes.
Yeah, so I would say it's very difficult to answer this question globally because it will be disease and drug specific. But in my view, given that we are dealing more and more with very narrow therapeutic windows, the pharmacodynamic will become more and more important. And while pharmacokinetics is very linear, in most cases, pharmacodynamic is not linear. And it's very difficult to predict what will happen if you don't measure. And in my view, in that sense, it's even more important to measure medication adherence in that situation.
Okay, thank you. Okay, next question is, opening a package doesn't necessarily mean that the patient really took the medication, and this might need to be coupled with serum level measurement. Is this combined approach being used?
Yes, so absolutely. The package, I would say, when we have a smart package, it's a measure of pill in hands. So we have a measure that the patient has removed the pill from the package. And it doesn't prove ingestion, that's for sure. However, we did several clinical trials where we have measured adherence using smart packages, and we have collected blood samples, pharmacokinetics. And it's not perfect, but we have less than 3% discrepancy between the observed concentration level and the predicted concentration level based on the smart package. So it's a very precise measure of drug ingestion. And the key of this is that the patient has to use the package every day to create a reasonable record. So it's very unlikely that the patients open the package every day and don't take the medication. So in my view, package entry is not the perfection, but we will never reach the perfection, but it's a very good measure of pills in hand. It's a very good measure of adherence of drug exposure in clinical trials. And the discrepancy with observed concentration is less than 3%.
Okay, thank you very much. The next question, is there data to look at whether low efficacy or toxicity is a significant contributor as a cause of patient non-adherence? Yes.
So there are data showing that toxicity especially, so that's, I would say it's called the feedback effect. And it's very clear that toxicity is one of the major drivers for poor adherence and especially for treatment discontinuation. And that's, in my view, why it is key in the future that we developed better dose and better dosing regimen. Because if we can have a dose that better balances efficacy and safety, meaning rather than going for the highest safe dose, going for the lowest effective dose, that will allow to develop treatments which have less side effects. And by having less side effects, you will have much less treatment discontinuation. Because today the trend is to go for a higher dose to compensate for non-adherence, but by picking a highest dose, there are more patients affected by side effects, and that drives non-persistence in the treatment. And the only way to solve that issue is to have a more precise medicine, a more precise dose selection. And that, with treatments which have a narrow therapeutic index, it will be key to improve medication adherence. But the feedback from toxicity and efficacy on adherence is very clear.
Thank you. Next question. Could you comment on the increasing use of non-inferiority trials and the importance of electronic monitoring for those? Adherence would seem to be more important in these trials than typical superiority trials.
Yes, and absolutely. And it's clear that in the non-inferiority trial, I would say the higher level of adherence, the higher level of non-adherence will increase the probability to show non-inferiority, to show equivalence. And so I think that authorities who are looking at a non-inferiority trial, they should require precise estimation of adherence to be sure that the patients have been optimally exposed to the new drug and the control drug, because else poor adherence could lead faster to the approval of a drug, which in fact is not even equivalent. And for example, if an extreme case is if none of the patients will take the medication, they will be claimed equivalent. So adherence is really important, and it should be documented. Even more important in non-inferiority trial, because it could lead to the wrong decision at the end. While in superiority trial, non-adherence will lead to the failure. It's a major impact for the pharma industry, but not for the people taking the medication, no final decision. But in non-inferiority trial, non-adherence has an impact on the drug that is accepted. It may mislead the decision.
Okay, thank you. Next question. This person agrees that adherence measurement is important, but asks, is non-adherence always a bad thing? There are examples where regimens were not fully understood in clinical development programs, and the real-world data informed a better dosing regimen.
Yes, and the question about is adherence not always is sometimes a good thing, I agree, because that's the definition that we have adopted for adherence. We start from the fact that there is an appropriate prescription. And the question, is the prescription appropriate? That's another process that needs to be better studied. And again here, in my view, if we look at clinical trials, it's important that we really understand what's the drug exposure so that we select the best dose. In medical practice, I think adherence has to be looked together with the prescription. Is the drug prescription reasonable? And I was last week at a meeting in the elderly population, and we clearly have to think also at the prescription. When an elderly person above 85 is on 12 medications, probably that there should be a better focus on the prescription, because some of the medications are clearly not necessary, and in that situation, non-adherence is good. But I think that's the process of prescription and de-prescription, and that should be a focus of a separate discussion, I think. But it's very important.
Okay, thank you. Looks like we have time for one more question. We had a lot of great questions today, and we couldn't get to them all, but we can certainly get back to everyone who submitted personally after the webinar. So the final question, there are many adherence solutions on the market currently. Do you have any comments around other vendors in the space, such as AdhereTech or Medication Control Systems, PillPod?
Yes, I think it's a good thing that multiple companies are starting to provide electronic measurement of adherence, package-based or others. I think it's key because we need different size, different shape, different features in the future. However, I would like to make 2 points. One is an adherence solution should not be time-based, because when you ask a patient what triggers his intake, they will say it's breakfast, it's dinner, it's bedtime. Very few people tell you it's 7 o'clock in the morning or it's 8 o'clock in the morning. So adherence solutions should not be time-based, because time is not an appropriate trigger to take the medication for most patients. And then my second point is we should not go too far. What we want is a reliable and precise record on how the medication are taken, to have a focused discussion with a patient. And some of the solutions today go too far, in my view, like putting the chip in the pill rather than in the pack. It's really intrusive. It adds a lot of burden to the patients, and it should be as simple as possible. I would say keep it simple, because when we are trying to solve the problem of adherence, we are trying to solve a problem that patients don't do. They don't take their medication, and we should not add burden to the patients. What they want is to take their medication in the morning or whatever the time and forget about their disease for the day. It's not something they want to think all day about it. They want just to do it and it's done. So simple measure with focused discussion at point of care, in my view, is the solution. And I would say keep it simple. That's the most important point.
Wonderful. Thank you so much. I'd like to thank everyone for attending this Fierce Live webinar and for submitting so many great questions. I'd like to thank Dr. Vrayens for participating and MWV Healthcare for presenting today's webinar. The webinar has been recorded. You'll be able to access the recording within 24 hours on the same page you used to register for the event. So thanks everyone again for joining, and we look forward to seeing you at future events.